right? Lots of drug interactions and stuff like that, right? So human, as an adult, human exposures. The most common ones are in this order. Analgesics. Why is that?
Because we're fun.
Because, so like when we have a headache, we're going to take our ibuprofen, Tylenol, or we'll take ibuprofen and then we'll take NyQuil and then we'll take Sudafed and we'll end up overdosing on those analgesics.
Okay, so what other kind of analgesics are a national problem?
Opiates.
Opiates, right? So you got national prescription drugs that are common overdoses. What's the most common one that we see?
Heroin.
In
Oxycontin.
yeah, there we go. So heroin is a big one, but we see more prescription overdoses than we do heroin overdoses outside of the city of Eugene, right? Because you guys all heard about all the craziness that happened over the last
It was
couple
something
months.
over December, wasn't it? With
Yeah.
the big.
Like
Well, there was
30,
there was like
30
fentanyl
and
and heroin
less
or
than
something.
18 days or something like that.
Yeah.
During heroin.
Yeah, I got
Yeah,
a
the
good
whole
one.
heroin
What
overdose
was
thing.
it called? The
Was it like
So you got carfentanil, yeah. So majority of the analgesic overdoses that we're gonna go on are just straight up prescription, your oxy, your morphine. So what have they started doing prescription wise now nationally in an attempt to help control this?
Probably giving you less days.
some database.
So basically they're giving you smaller amounts of prescriptions, less dose, less strengths, and they're making it much, much harder to refill prescriptions, right? So they're basically trying to get you not hooked on it. So what are they gonna start to prescribe you? Ibuprofen, Tylenol, right? How many people that are on the analgesics for a while like ibuprofen and Tylenol,
Cut the mustard.
right? I told you about the dude that we picked up that had this super angulated arm.
Yeah.
That was
yeah, you
a
told
drug
me.
seeker, totally bamboozled us all. It was just like, holy, you guys pulled the fast one on us, right? All right, cleaning substances. What do people drink? The go-to drink.
Bleach.
Bleach. Oh, the Bang. Yes, there you go.
Cleaning.
That will clean out your intestines and everything else, depending on
Bleach
how-
for suicide attempt?
Yeah, so people will commonly drink bleach. It is the go-to, holy moly. You got bleach and then you have the ammonia cleaner. Go-to or the go-to? What kind of substances are those?
Caustic.
Basic?
I heard it.
Caustic.
Caustic type substances. What does that do to the tissue and stuff on the way
Right
down?
up.
Turns into soap.
You turn it into hamburger?
Turns into
Basically
soap.
It helps them.
It's like
Doesn't
like really
it, doesn't
basic
it
things
take
will make
away
your
the
skin,
phospholipid bilayer and so ruptures all the cells?
Everything becomes,
They call
I
it
like to
soap.
describe it as like a hamburger approach. So what, if somebody
I
has
like my
drank
word choice. Stick with
bleach
it.
or ammonia, what is that telling us as paramedics? What thing in the management of this patient are we now concerned about?
Airway, sepsis.
Okay, so let's talk about airway management. What red flags are going off right now if somebody drank bleach?
Aspiration.
Oh, you're getting a diminished level of consciousness. Oh, we gotta take over an airway.
When I start innovating it,
Suction.
and destroy it even more.
Oh, you know what? It sucks. You can't get your innovation because you're not very good at your skills yet. Okay, check. Got it.
You might not
Well,
even be able to get rid of steel.
now what?
It could be eating holes through.
You can't get your ET2. Okay. Yeah,
Just
suction.
the king anyway is just gonna do more damage. Don't worry about it. No.
King airway. That's pretty much what I heard from that.
That's pretty much what it was.
Okay. So what do we? So this sends up a red flag in relation to the king airway, correct?
Yeah.
Oh,
Yeah.
now you guys are like, oh yeah, right?
Because you've damaged your esophagus.
Okay. So what is one of the contraindications of a king airway?
Damaged esophagus.
Caustic substance.
Caustic substance.
Seems right.
Oh, you're right, but yes, you were just so far away. Specifics, man, specifics, come on. Right, so these are things where we gotta think ahead, be like, oh, this is bad. Boom, red flag starts going off, you're like, okay, we've got to make sure we get this ET2 because we don't really have a secondary device, right? Do we have a secondary device for this?
We could bag them.
Right.
But if
We
you're
always have a
thinking about
secondary
it-
device, right?
Yeah.
Are we really gonna crank somebody though that no. But you always have a secondary device, right? So what has the potential if you stick a king tube down in this?
It's all in the bag.
You're gonna esophageal varices.
Yeah, you're gonna start rupturing vessels. Oh, has anybody had an esophageal varices patient?
Yes.
I had a friend that wasn't a patient,
Oh.
just a friend
Okay.
that had it happen.
So when I say esophageal varices, there's two different types of esophageal varices patients. You have the ones that they tell you they have esophageal varices, and you're like, oh, okay, we gotta be careful. And you have the ones that they don't tell you that they have, and it has ruptured. What kind of patients are those?
Critical.
Dead.
Those are usually your cardiac arrests at that point, right? So when you
Tonsils.
stick a king tube that you don't really realize that this person has esophageal varices, you stick the king tube down in there, what does that now turn into? A giant nozzle, right? So you can point the end of your tube at anybody and you can like spray blood. There's so much blood coming out of it, right? So how do we manage that? Like you laugh, I'm totally telling you the truth. I can't wait till you guys get out in the field and start seeing some of these things.
ET
Right in
tube.
the face. Is that the cardiac arrest?
So it's just, these are probably, other than trauma, these are the hardest airways to manage because you cannot keep up with a true esophageal varices rupture. You cannot keep up with the blood management suctioning.
Trick pressure.
It is the messiest, like I kid you not, like if you have this, we'll say this patient right here is your patient, and we're doing some airway management on this person. Okay? We're doing airway management on this person, and they got this ruptured esophageal varices. So you know what we end up doing with our towels and stuff? Basically wrap that up, right? Because what's that gonna do? Yeah, it's gonna absorb. So we're gonna take 2 seconds, then we're gonna grab a new one, right? Because what we're trying to do is we're trying to manage this the best we can, but when there's blood just basically just flowing out, what does that do to our management ability? So if you have blood just all over here and you're trying to get a face mask seal, you're trying to get this, you're trying to get that, and you have just this constant blood just flowing, it makes everything so much harder to manage. So if you can get anything that has any sort of absorbent ability to it, and then just basically just set it on it and help it absorb so you don't end up rolling around in the blood.
So would
because
you-
that is something you will legitimately end up doing.
You had talked earlier about taking your suction and just sticking your suction in their mouth.
Yes.
Is that pretty much what you do? And
Yes.
will that suction keep up or not?
Depends on the bleed.
Depends on the bleed, but a lot of the time you won't have enough in your canister ability. So this is one of those things that would be like, okay, we're gonna need multiple suctions, we gotta have this stuff rotate now, because you're gonna fill up your suction canister probably within 5 minutes of trying to manage this airway. So lots of blood in those esophageal varices.
Would you take the king out after you cause said damage
Son of a, now what's gonna happen?
and you know? Well, I assume it'd make it worse, but would you want to try and like
Would it
intubate?
make it worse?
Well, why would you, if you put a king in first, and now you're trying to intubate,
Why didn't you
explain
just
to me your
intubate in the
reasoning.
first place?
Is it working? Is it controlling the airway or not? Would be the question. The king.
No, let's back up to the question first.
Say an
Say
EMT
one of
dropped
those
the
EMT
king.
idiots didn't know their contraindications for a king
Well,
too.
if they were unconscious and you didn't know, and
Okay.
you kinged them,
Okay, you're gonna king them.
and said thing happened, would you take it out and try and intubate?
What would you do, Noah? You are the paramedic to make the decision right here, right now. You have less than a second to make it. If you would stop chewing for 2 seconds so that we
If
can
I was
answer-
getting a capnography reading, I'd leave it in place.
Oh my goodness, that's the most horrible decision. No, it's not horrible. It's just not the best decision.
Right.
Well.
Debate through the king.
So, who here wants to place an ET tube in this person? And they have a king in place, but they have ruptured esophageal varices.
And there's just blood
I mean, I
pouring
want
out of
to,
the
Blood
but
is
I
mouth.
don't
pouring out.
know.
I'll let them say it.
I feel like it'd be really hard.
I wanna crank them.
Oh, Sarah wants to cry. Okay.
So always a way out.
I mean, I'd want, with an 18 gauge, yeah.
Okay, so this patient is somebody that I'm going to want to make sure that I have an ET tube with. Okay? Because what is the difference in the way that a king tube versus an ET tube are placed? Where does the ET tube go?
In the trachea, below the
In the
vocal.
trachea. If there's blood outside the trachea and you have an ET tube placed,
It should
can blood make it into the trachea?
theoretically no.
Theoretically, no. Correct. If you have a king tube placed, can it make it into the trachea?
Yes.
Where's the blood coming from?
The esophagus.
Esophagus.
Does that answer your question?
Yeah, I just feel like it could potentially be really, really hard to intubate a person with that much blood. I don't know.
The king helps you though. You can intubate through the king.
Don't listen. Ignore Dustin right now. Ignore Dustin.
With a bougie?
We're gonna put Dustin in timeout. Okay? Okay?
It's gonna sit back.
So with a difficult airway, is this gonna be difficult, yes or no?
Yes.
Yeah.
Why is it gonna be difficult?
Because there's blood blocking everything you can see.
Perfect, okay, so you're gonna need to suction as you go in, right? Suction, 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 this is where we talked about, just leaving that suction there. Take your tube, pass your tube, okay? You guys are gonna be the best ET tube passers ever, though, right? Oh, man, you know what, there's nothing that makes me more angry than watching somebody that didn't go through lane try and intubate somebody, because they are bad in the field. Just really irritates me. Saw one of these the other day. I'm just like, having these moments where I'm just like,
Give me that.
I'm like, so I'm just like sitting up and I was like, so you need me to do that for you? They're like, I just don't see anything. I was like, well, I'm pretty sure that you're pretty much sticking it out the guy's anus right now. A little bit. And it's like, I'm like, hey, so do you have any landmarks whatsoever? I don't see anything. I'm like, yeah. So think about where the end of your blade is, right? I'm like, and this is a practicing paramedic, right? But they got their own way of doing things, right? You guys all do things virtually the same way, right? Same kind of technique, same thought process. You can tell, like, I love watching lane students innovate. Like, there's a little part of my heart. I'm like, yeah, get it. There you go. But it's like legitimately, like, I'll sit there and I'll be like, hey, so you gonna get this tube? And they're like, yep, I got it. And I was like, okay, remember, go in there, use your self maneuver, use your hand. And it was like I'm thinking that in my head. I'm not saying anything though. I'm just like, I'm watching, like, they go in, do their self maneuver, and it's like, yes, 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 you're remembering. And it's like, oh, all my time and effort wasn't a waste after all. The lane students are super, super successful compared to people that have gone to other colleges. And I don't say that just because I'm here with you guys and the other students. It is significantly a night and day difference, okay? So, sidebar there.
The same thing with basics.
Basics are awesome too.
No, just the basics that come through this program and then the others that come through for state testing, you can tell the difference.
Yeah, it's, I love,
I'm not tooting my horn, I'm tooting the program.
I love lane students. All right, pediatrics. Oh, what's the first thing pediatrics, what they get into?
You know,
You take it every day.
Yeah.
So why don't they get into the analgesics compared to the personal care products?
because they have child-proof box on it,
Where do people leave their personal care products?
on the counter.
On the counter, easy access, right? Underneath.
Or they
the-
get into the weed edibles.
Only in your.
I had a kid that OD. Well, he didn't OD, but he was zonked.
Happiest day.
No, I don't think we're allowed to talk either one of us.
Boy, Noah's having a rough day today. Rough day. But Noah, I'm glad you showed up, okay? I'm glad you showed up.
Why do you think he's eating so much?
I know, he just is like, I just need to keep my mouth shut. I need to keep my mouth shut. I need to keep my mouth shut.
I'm
He's
so
always got the munchies,
Oh,
always
he's
hungry.
been on the weed.
Munchies, okay, so easy access to these. So what types of products would you see kids eating?
Lipstick,
Lipstick, cleaners,
Lotions,
lotion,
paste.
Nail polish.
nail polish. Ooh, that's a yummy one. I mean, not that I've tasted it, but how about like Desitin?
what's that? Oh, but
Diaper rash.
Diaper rash.
How about baby powder? The funny thing is, because what do kids do with baby powder? What do they have fun doing? Well, what do kids do once they? They're like, oh, that looks yummy, and then they start trying to eat it, right? What does baby powder do when it's added, when water is added, saliva is added? Can this be a significant airway potential issue? Yeah, absolutely. How about Desitin? Oh
Yeah.
man, I had a kid take an entire tube of Desitin and just, and like it was like all over the mirrors, and it was all over everything. I don't know if anybody knows. Right, never have a rash ever again. But how easy is it to get Desitin off?
It's not easy.
Because it's designed to be wet and not come off when it gets wet, right? So yeah, this stuff does not move at all, right? So you're like trying to wipe and like the kid's skin's like coming over there, just like, okay, kid doesn't like that. What's our concern?
Airway.
Airway, right? So what do we do if we have a kid that takes something that we don't know if it's bad for him or not?
Poison control.
Who here knows the phone number for poison control?
Two, two,
I don't know,
two,
but
two,
I'm
two,
saying.
two.
No, you guys gotta know this one.
Is it just two straight across?
Poison.
1-800
Poison.
222
Oh,
1222. Super easy one to remember, right?
I just had
Yeah. Is it, are they helpful?
Yes.
Are they helpful? Thank you, Chandler. I like the eh. Has anybody here ever called poison control?
They call it doctor.
How did it go?
Mine went fine.
Yours went fine?
Uh,
So what was the substance?
My
You know?
daughter ate
Pepper spray.
borax, or the ant poison with borax in it,
Ooh.
and the lady's like, it's borax, it's okay.
Okay. You got it. It's okay. It's okay. Who else? Allie.
Brother-in-law pepper sprayed himself.
Yeah, that's totally-
Happened to do it with his mouth open and ingested quite a lot. So
Like
my
Banaka?
sister-
Thinking it was Banaka?
Yeah. He was, yeah, he was about 5, so.
Good to go.
Your brother?
Oh, he's 5.
So what they say?
Those are wild rides.
The poison
From
control
Alabama.
told his mom to call a doctor. Oh.
Oh, okay. Call a doctor. All right. Who here has called them from a pre-hospital setting? Anybody? Nobody.
Nothing I can recall.
Janae? Is that a yes or is that a no? I couldn't really tell what this little.
Like at home, you're saying?
No, like as a responder.
Oh.
Anybody?
I don't remember it though.
Okay. So I'll give you a little hint. Calling as a parent is so much easier than calling as a responder. Because you call them, because most of the time we call them, hey, this person overdosed, they took these pills, hey, we need to know what the reaction potential is and what the lethality is. Lethality? Did I make up a new word?
The bad
Word?
part, the badness.
Okay, the badness of it, yeah. Are they gonna die right here, or like is this something that they're gonna be fine, right? So they wanna know what department you're with, and this and that and that. It's like, it's gotten to the point now where I'll just be like, hey, so, what does this drug do? And they're like, oh, well, we need some information. I'm like, nope. I just wanna know what this drug will do to somebody, because they're like, this person, because they'll say, we have a totally alert and oriented person, that they took something, and they're like, this person needs to go to the hospital immediately. We're like, well, great. They're saying they don't want to go. We want to tell them what the risks are associated. They're like, nope, you have to transport them. We're like, I don't think you understand. We can't kidnap. They're like, well, we're going to call the cops on them then. I'm like, the cops are here. I don't think you understand.
They told you that?
Yeah. And so I've just had to run around, and so I've gotten to the point now, what's the easier way to deal with this?
I'm a parent.
Google!
Yeah.
Right? You just Google the stuff, man. So much quicker to figure out what the interactions and lethality of it is. But as a parent, they're super helpful. If you, like, they're quick and they give you all the information, they're like, yeah, you should probably call the doctor, let them know what happened, versus us in the pre-hospital setting. Okay?
Do they ask you all that information as a responder for like demographics or I don't know, research or something, or just legality?
Yeah, just legality stuff. So we had one where, I think I told you guys that overdosed on all the Benadryl capsules. Somebody got into a tunnel and they decided, hey, we're gonna call and figure out, and they're like, oh yeah, this person, it was a cardiac arrest, but we're like, hey, is there some sort of antidote that we can give for all this Benadryl? And they're like, oh yeah, no, there's nothing that we can really do. And we're like, oh, okay, yeah, so we're working this code, and this is where that carfentanil was actually sitting on one of the end tables that we didn't realize we could have knocked over. But then like 5 minutes goes by, and all of a sudden dispatch is like, hey, you need to call poison control back. And we're like, what? And so the tech that was running the call calls poison control, and they're like, hey, so yeah, we talked to our physician advisor, and the physician advisor wants you guys to give 2 amps of Vicar. And we're like, okay, well that's something that's kind of out of our scope of practice, right? So now we're going from another doctor, so they say, it's coming from another doctor, is telling us to do something that's a little out of our scope. And so we're like, so he's like, hold on, I'm gonna put you on speakerphone. So we're there doing cardiac arrest, and we're like, hey, you're on speakerphone, there's like 9 paramedics here, and we're doing cardiac arrest, and you hear this like operator be like, okay, so Dr. So-and-so says give 2 amps of bicarb, and they tried to explain what it was, and we're like, and then so the tech goes, so are we good with this? And everybody kind of looks around, and we're like, maybe we should make one more phone call.
Cool.
And we called our doctor, and we're like, hey, this is what they said, and the doc in the ER is like, well, that doesn't make any sense, but if it came from poison control, yeah, go ahead and try it. We're like, okay, so we gave him 2 amps, and we got Ross, but then the person later died down the road. But it's just that
After
kind
the
of thing.
sodium bicarb?
What's that?
After the sodium bicarb?
Yeah, yeah.
Like right after, or?
No, it was a good another 10 minutes or so. But yeah, but it's just interesting. You're gonna get those types of information where it's like, okay, we're getting weird information from them now. So, all right. So overdoses that lead to fatalities. Okay, take a look at the top one there. Why do you think that's the top leading one?
Because they take it, they lose their drive to breathe, and they go into hypoxia, and nobody witnesses.
Because they don't
They
think they
drive.
can overdose on it, or they take it with alcohol?
So just look at so instead of looking at like how it combines with other stuff, just look at the type of drug it is.
Sedative,
Okay.
Hypnotic.
So if you have a sedative or hypnotic, how frequent are those out in the general population? Is there a lot of it?
yeah,
Yeah.
Is there more than you actually realize?
yes.
Absolutely. Is it almost most patients have some sort of sedative built into their, like they're on Ativan or something like that?
A
Some sort of
benzo.
med, something that's in there, right? The amount of people that have anti-anxiety meds is through the roof. And so a lot of times they have large amounts of them, okay? So if somebody has anxiety or they get wound up or depression or something like that where it just really affects them, they have this massive amount of medication available to them to be able to take these drugs, okay? Because people normally just overdose on cardiovascular stuff, right?
No.
That's like, there's really not a underlying psychiatric issue associated with those, right?
There's not like a high you get from a cardiovascular drug, is there?
Not usually, because what cardiovascular meds do you usually get?
Beta blockers?
Beta blockers, right? And so what does that do? Does that wind you up and get you high and excited? Or what does that do?
Just
Right? What does beta blocker do to your heart?
slows it down.
Slows it down, right? So, not ideal. Opiates, we already have talked about those.
So I was talking with one of the ER docs about benzos. It was more so like for our cardio
Stop
version.
talking to Swink.
It was me.
I know.
But she was talking about overdosing on
You can't overdose them
benzos.
on the benzos.
What's that?
No, go ahead. Yeah, no, yeah.
I'm just curious what the overdose process is on benzo. Like an opioid, you overdose process, you're going to lose your respiratory drive, stop breathing, then go into cardiac arrest. What's the overdose process with a benzo?
What do you guys think with a benzo? How do you think that works? It's a sedative. So what does that do to your LOC?
Lowers your LOC.
Lowers your LOC. When you have a decreased LOC, it doesn't necessarily affect your respiratory drive, but what can it affect?
Your ability to regulate your airway.
Yeah, the ability to protect your airway, right?
You're just like-
So kind of like with alcohol, right? So you pass out, you're laying on your back, and now you lose control of your ability to regulate your airway, right? So now you end up having occlusion. What's the number one occlusion when you're supine?
Your tongue.
Your tongue, right? So now you end up with a partial occlusion, which then causes you to become hypoxic. Doesn't really necessarily affect your respiratory drive. You're still trying to breathe, but now you are sedated to the point where you're unable to protect your own airway.
Thank you.
Okay. All right. So acetaminophen.
Tylenol. Is this going to be like the Tylenol combination where I took Tylenol and then I took Sudafed?
Nope. This is I have a bottle of Tylenol right here, and I just took the whole thing trying to kill myself.
Big lump in your stomach, isn't it? Okay.
You're going to destroy
Why do you think
liver.
it's up high here?
Because it's
Because it happens
accessible.
often.
It's over
Because
the
anybody
counter.
can go out, and how many people have Tylenol in their cupboard?
Everybody.
Everybody, right? Everybody has Tylenol, everybody has acetaminophen, everybody has
Not
ibuprofen.
dying.
they have these easily accessible to them, right? And so nobody really knows how to, I mean, now that there's the internet, people are figuring it out a little easier, but when they see pills, they know the idea that, hey, if I just take a whole bunch of pills, this is gonna do it. What does Tylenol overdose and ibuprofen overdose do?
It's gonna wreck your kidneys.
Is that
and your liver.
is that a quick, hey, you're
No.
gonna die like that?
No.
Or is it a, this is gonna suck for you?
For years to come.
Years come, what's it wreck?
Your liver.
Your liver and your kidneys, right? So it trashes those. Makes it so that you may end up even potentially on dialysis. Kidney failure. Yes.
I heard something about.
I heard something once too.
It was actually on maybe 60 Minutes, but they were talking about acetaminophen being so toxic that the FDA would not have approved it today because its limits, its safety range is so narrow.
That the toxicity of it is so high compared to the functional ability of it.
Yes, sir.
All right, that would make sense.
It kills something like 30,000 people.
How many people in here have ever taken Tylenol? How many people here have ever taken more than the allotted amount that they tell you to take? Right? So that's part of the problem, is just like, yep, back to orders, yep, I don't feel good, gotta take some more, right? Same thing with ibuprofen. I'm pretty sure that my kidneys are gonna be shot from ibuprofen use when I was younger, because it's like, hey, yeah, what's the normal dose of ibuprofen? 2, right? So 800, so it's like, it's
No,
roughly
not
4.
800.
Yeah.
800's 4. They're 200 mgs
200
each,
per, yeah, so it's normally 2,
which is 400.
400. But yet,
Just saying.
8 is the throwdown go-to prescription, right? And so what do you do if you want 800 of non-prescription? You just take 4, right? So it's that kind of a approach. Alcohol, death, dying, alcohol. How are you gonna die from alcohol overdose?
It's gonna aspirate on your vomit.
Then you can't breathe.
Alcohol toxicity.
So this is what happened. So there you were in the bathroom with your head in the toilet. It's all based on drowning, okay? You drown in the toilet every time. Nothing to do with vomiting or any of that. You drown in the toilet every time.
How many toilet drownings have you been on?
Oh, every single one of them, not really. Oh, antidepressants.
Isn't that up at the top?
Those are more sedative.
Sedatives.
Yep.
Yeah.
Antidepressants, TCAs, your tricyclic antidepressants. Your TC. So your TCAs are one of the most lethal medication to take, to overdose on. So basically 1 week's worth of TCA, so like amitriptyline, 1 week's worth is fatal, right? How many do they prescribe at a time? A month, right? It used to be that they would give you 3 to 6 months worth, and then they realized that that was a really bad idea to give people that were having
Depression
issues already. And so early on in the amitriptyline approach, they ended up having many more overdoses after they were started prescribing the medication. All right, here we go.
What were the last two on there?
SSRIs
SSRI,
and
antihistamines.
SSRs and antihistamine. So there's our Benadryl. Okay, 17-year-old female, unresponsive at home in the morning. Oh, so the first thing in the morning, you guys respond. Empty pill bottles belonging to her parents. Oh, of course they're not her pills. She's only 17. She wouldn't have any sort of prescription meds at 17, right? Wrong. Okay, so we got some pill bottles. Oh, quite a few of them. We got Oxy, we got some atenolol, gabapentin, sertraline, and metformin. What do we know about Oxy?
Opiate?
What's that gonna do?
Slow down
To take down a respiratory drive.
Atenolol.
Yeah.
Alol. Alol.
Beta blocker.
Metoprolol. Atenolol.
Beta
Alol.
blocker.
Beta blocker.
Block.
Bit of block. Bit of block.
Walk.
It's cutting it down.
Alright, beta blocker. What would we expect to see?
Low heart
All
rate.
right.
Okay. Gabapentin.
It's
Penton.
Says,
Antipsychotic?
neuro. No, it's for nerve pain.
Nerve pain, okay? So not probably something that a 17-year-old would have, okay? Sertraline.
Did it knock out the nerve impulse? Is that what that was?
I'll tell you in about 3 slides. Okay, sertraline. I don't know, you tell me, Andrew. Andrew's saying that it's an antidepressant. Does anybody agree or disagree?
I don't know, but I'll go with them.
We gotta look it up.
Yeah.
Hey, you guys are on scene, I mean, you gotta know what to expect.
I'd follow Andrew the answer here.
Hold on, what is Noah doing?
Antidepressant.
I said I'd follow Andrew.
You're following Andrew, putting everything in Andrew's.
I got you too, man.
Does anybody else want to use a resource and figure out what these are?
Yes. I was about to say, can I just Google it?
It's for major
Absolutely.
depressive disorder, excessive compulsive disorder, panic disorder, post-traumatic stress disorder, premenstrual dysphoric disorder, social phobia.
It's the Aline.
For a binge eating,
The
bipolar,
pentine, it didn't work.
post-depression, cerebrovascular
Celine
accident,
is a SSRI.
mood swings, depression, dysrhythmia, night eating syndrome, non-cardiac arrest, chest pain, premature ejaculation, severe major
Okay, so one more time, Mark, what's the main thing?
depression,
Depression, so antidepressant, metformin.
For diabetics.
diabetes, type 2 diabetes.
Type 2 diabetes, so what are you gonna expect if somebody overdoses on metformin?
They're gonna have a low CBG.
Okay, so think about it. Metformin, what type of diabetic is it for?
Type 2,
So what is it attempting to do?
eat the sugars in there because they're too high.
Okay, so if it's gonna eat sugars,
It'll have heart.
what's it gonna do to your sugar
I'll
level?
do a
It's
little
gonna
bit.
dump
Too
it.
much sugar.
Overdose.
You're overdosing, you took too much of it, right? So yes, if you eat just the right amount, then it'll be like, hey, we're
Or
gonna
if you don't eat it, then.
right, then it's gonna climb, right?
Oh my
Okay.
God.
So,
Just going
how do we
from
wanna
muffin
manage this
top.
person? Oh man, wait, there's some social history here that you guys are definitely gonna wanna know. Stressful home situation, recent departure of the father.
What do you mean by departure?
Patient's medication, none and none.
That didn't change how I was gonna do it.
Well, all of those medications are going to adversely affect the patient, because none of them restore him.
So, patient says that they take no medications.
Wait,
I thought
They are
that was-
prescribed none.
she's unconscious, how did she say
Sorry,
that?
mom says,
Mom
says.
Great.
The non-departed father, the mom that's still there.
So that means they don't have diabetes and they're giving medication for
Okay,
it.
so they don't,
have
so, there you go.
beta blocker
That right there is
problems.
some of the key
Don't-
stuff. They do not have any of these underlying conditions. They don't have the cardiac condition. They don't have pain condition. They don't have the diabetes. So all these new medications that they are introducing are not something that the body has already built up a tolerance to. So it is a brand new introduction of who knows how much of each one of these. How do you figure out how much they took? Is that important to us?
Yes.
We do a blood.
Okay, I want to know who here is good at math. Oh wait, no, I know you guys all suck at math, right? Is math important right now?
Yes.
We need to figure out exactly how much they took of each thing, right? How do we run this math?
Count the max that the prescription says and subtract the amount of
Okay.
pills that are left.
Oh Jesus, hold it. So you look at what now?
It just says that the bottle says it had 30 and there's 15 pills left in it, you assume they took 100.
But didn't it say the
But
bottles
you
are
also-
empty?
But you also need to count.
All the bottles are empty.
If the bottles are all empty, just assume they took the
How,
whole
what day
bottle.
of the month?
Nope, not yet. You don't assume they took the whole thing.
What day of the month is it? And so how many days are left?
There we go. So, what those two back there said. So you look at when it was filled, okay? And you look at the potential for how much was supposed to be gone on a normal use, right? Because mom is there.
What if they were from the departed father who departed earlier?
Well, mom just gave us she's a good historian and she just told us that.
She just told you all that stuff. Noah, I'm gonna take all your food away, throw it in the garbage, so that you can function. So that you can focus just for like, we just need you for like another half an hour or so. Okay, so you wanna look at the date of that the prescription was filled. You wanna look at how much should be gone in relation to how much should be left, right? And that's how you run your rough math. And so when you say, you show up at the hospital, you tell them, hey, this is how much medication should have been in there. We talked to mom, mom's been taking all the meds appropriately, so that is how much is missing. Do we know that she took the medication? No, but we know the amount of medication that's missing. She could have taken all those pills, dumped them down the toilet, but we just don't know. So we automatically are going to assume, and now we're gonna start to build our case based on what? How are we gonna build our
Vitals.
case?
Based on her vitals.
What's expected.
Okay, so a normal person, what would their blood sugar be?
High, or 80 to 120.
Okay, so if we had somebody that overdosed on metformin, what would we expect?
Super low.
Okay, so this is where we start to be those thinking
Blood sugar.
paramedics, and we start putting things together and building our case that says, yep, I think that this person overdosed on these meds, right? So we're gonna have physical presentation and vital signs that are gonna start to present that way.
All those, well, a lot of those drugs are going to
Do something.
do something on the other too. An opiate and a beta blocker and a,
Those are all like
they're
downers.
gonna, what's the word?
They're systems.
Where they work?
Synergism?
Synergism?
They're all gonna work, yeah, they're all gonna work together
Synergistic
to make
effects.
things worse for you,
Yeah.
right? Okay, so what's our differential diagnosis for this?
For just an unresponsive person?
For the, we got this 17-year-old female, what's our diagnosis right now?
Overdose
Do
on
we make diagnoses?
Yes.
Yeah.
working theories.
Do we make educated choices?
Do we make educated guesses?
Yes, educated guesses. We don't diagnose anything.
Same, but different.
Same but different, right? Yeah. Okay, so are we going down the unconscious, unresponsive protocol here?
Yes.
Yes.
How many people thought about unconscious, unresponsive at the very beginning when you had the 17-year-old unconscious person? How many people immediately thought to themselves, I'm in the unconscious, unresponsive protocol? Okay, being honest, okay, show me some hands that said, yeah, we're in this protocol. All right, so you guys should start automatically, every single time you guys have a scenario, immediately put yourself into that protocol, okay? Into that algorithm, so that it gets your thought process thinking, hey, this is where I'm gonna run with this. Because that gives you the start of your ability to start your assessment. Right? So as soon as you have that unconscious unresponsive, be like, boom, okay, I gotta do blood sugar and I gotta check the pupils because I'm looking for narcotic overdose. Okay, whew. Those are clean, quick, easy checkoffs, right? Okay. What kind of evaluation do you want to do on this person?
ABCs.
ABCs, thank you, Justin. 12 lead, good. Way to jump right at the advanced stuff. Going, skipping all those, BLS skills. Airway management with an unconscious person. That potentially overdose on opiates. And maybe some sedative, antidepressant stuff. But hey, we need a 12 lead because what are we going to do with our 12 lead?
They don't have an MI.
Non-ST elevation. Okay, good. We found that stuff out. The patient hasn't been breathing for a little while, but hey, we're good.
17 years old, but
We're
she's
good.
got an MI.
Hasn't been breathing, doesn't have.
17-year-old's not
Right?
a hard category.
So to take a little side joke, not to throw you under the bus, but this is a common thing that as new paramedics, I hear quite frequently of, you guys will come up and be like, hey, we need to hook the monitor up to this trauma patient. Okay. Can you feel a pulse? Do they have a pulse? Well, yeah, they got a pulse. I'm like, okay, so what are you hoping to figure out? Whether or not they're having a massive heart attack right this second, like with ST elevation, like right now? Or do we want to manage the BLS, ABC stuff first?
Swimming blood.
And so it's a very common thing. You guys have all these cool tools now. You're like, I need vitals. I'm with the monitor hooked up because that's how, like, you've been trained in the past to use all these cool tools. Okay. Now we got to go back. So we want some exam stuff. We want information, right? What would you expect to find with this patient? These are the types of things where you want to try and figure this stuff out.
Low heart rate, low blood pressure,
So you're looking for these things, right?
low
So
CBG.
you have expectations and you're hoping to find it. Yes?
Yes.
Okay.
What would we expect with a gabapentin overdose?
Ooh. What does it mask? Oh geez.
It's the nerve pain.
What is it masking? What?
Sensation.
It's in and out.
So it wouldn't just like painful stimuli, it would
Okay. So before we get to that, so what, any sort of decontamination this person needs to go through? Decon? Anything?
No.
What, did they snort most of it?
Any specific antidotes that we can think of?
Narcan, D50,
Glucagon.
glucagon.
Maybe
Yeah.
activate.
Oh.
Glucagon,
Pull
way to
in.
go.
Okay, so did everybody catch all of those?
Yeah.
3?
I missed one, but now I caught it.
Yes, Levi.
Did you catch those? Okay, you looked a little stressed out back there. Now you're good? All right. Yes.
Do you use a B50 and a glucagon, or one or the other?
Oh.
Depending on
Oh,
the
man,
access.
no.
So,
just-
No,
here's the question.
Wait,
No.
I have about
No.
One or the other.
in the
So the glucagon is not being used for the low blood sugar,
Right.
right? So what is the glucagon being used for?
Dun, dun, dun.
Dun, dun, dun.
but
Beta blocker, beta
you're-
blocker.
We can use
You can also do calcium channel blocker too.
Yeah.
well, you're
Do we
supposed to give
have- do we
IV
have-
calcium.
Is this
first.
person
Call it in,
overdosed?
man.
Has this person overdosed on calcium?
No.
Blocker?
Not beta blocker.
Just a beta blocker, right? So what do we have in our protocols for beta blocker overdoses? Glucagon.
Glucagon.
Okay. So Noah, now I'll let you. You were going glucagon for that low blood sugar. You're like, yes, no, this doesn't work. And like, wait, now I just threw a big
No,
curveball
no.
at you.
Was it so? Is it for a calcium channel blocker overdose? You give IV calcium first and then glucagon.
Calcium channel blockers.
With the
Okay.
beta blocker.
But that's better.
But none of those were calcium channel blockers.
None of those are calcium channel blockers.
Right,
Okay. All right. So let's see. Causes of unresponsiveness. We got the overdose. Infection. No. Hydraulic disorders. No. We've got these. Standard workup with the unconscious. Okay. Got all those. Boom. Okay. All right. These are your vital signs. Here we go. Heart rate 52. Blood pressure 70/48. Respiratory rate 8. Holy moly. Temp 37. Oh, unresponsive membranes moist. Supple neck.
Supple. What?
That's very.
What?
It's a supple neck. Just in case you want to nibble on it, Mark. Pupils are 1 to 2. React poorly. Bradycardia. Lungs are clear. Abdomen's no bad.
No BS?
No bowel sounds. Warm, dusky, dry. Neuro, non-focal.
What's non-focal?
Like nothing's focused. They're not moving. They're not doing anything.
They're
like that.
unresponsive.
They're responsive, but there is some sort of maybe movement, maybe some.
But not intentional.
Yes, isolated, like not localizing pain. Okay.
You go to CBG yet?
Oh, you want a CBG? What do you want to do here? We're not to CBG yet, are we?
Airway.
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 Happened beforehand?
Okay, back.
Respiratory of 8 though, or
Wait,
airway.
How would you get it before?
Hold everything.
Oh.
Unconscious unknowns.
Okay, but before you get your unconscious unknowns, you have to be managing what at the same time?
Airway.
You gotta be managing that stuff, right?
But not-
Do we intubate this person?
No, not yet.
No.
No.
Good, not yet.
Are they managing their own?
I'm holding back.
So that's the question, is whether or not, how do we check to know if they're managing their own airway?
You check it.
You do your
You do Yes, we check it. So, Blake, you just open the airway?
Snoring, respiration.
Do you shove your laryngoscope in there to test?
No.
Do you, I can make up all kinds of fun stuff right now, Blake, but how do we check it? How do we check to see if somebody's protecting their own airway? Think of it just in a trauma.
You just open their mouth and you look at.
You listen.
Yep, I can't tell if he's protecting his own airway. I'm looking in there, but how do we protect it? How do
With
we
their gag
know?
reflex.
Okay.
Hold on.
Okay.
How do we know if Dustin's gonna protect his own airway?
Do it, just do it.
Let's try. This is not good.
Blake? Blake?
Okay.
Hold on, Blake.
So, OPA.
Okay. Man, I thought we were gonna really have a hard time. So just by opening somebody's airway, you don't know if they're gonna protect it or not, right? So you have to check with an OPA with somebody that's unresponsive, right? So a lot of that's gonna be based on the type of painful stimuli, verbal stimuli, on whether or not you're actually legitimately gonna try it. Your jaw thrust is gonna tell you a lot as well, because what do most people not like with the jaw thrust?
Pain of it.
They don't like the pain of it, right? If they pull back from the jaw thrust, are they more than likely not going to take the OPA? Probably not. Okay. So we're going to check it. We can stick an OPA in. Probably not going to take the OPA. Then what?
No facial trauma, then you go APA.
There we go. So this patient gets an MPA. Does this patient need to be assisted?
Yes.
Okay. Okay. All right. We got through that airway and breathing part of it. Good. Circulation. Good or bad?
Not good.
Heart rate of 52, blood pressure's low, so not good.
Warm, dusty, dry.
Everything but the temp's crap.
Everything but the temp is crapped. Okay, good.
The heart rate isn't that.
What about the supple neck? Is the supple neck bad?
But it's unstable.
I don't
Like
understand
70.
what the description of
Look at
the
the blood
supple neck
Yeah,
is.
the blood pressure is
Okay.
crap.
I'm guessing like maybe no retractions or no JVD, maybe.
Because they're low, but
What?
But because they're on a beta blocker, they can't increase their heart rate to help their blood pressure.
Yahtzee. Oh.
Which is
So
why-
you need to
it's a-
figure out how to get their heart rate up to get the blood pressure up, because the beta blocker.
Oh, finally, Dustin.
Did I redeem myself?
Finally, Dustin, I don't have anything bad to say.
So, did everybody catch that?
Yes.
The understanding with the beta blocker. So what is the normal response when somebody has a low blood pressure? What is the body's? You have an increased heart rate, right? So that is the body's attempt to regulate low blood pressure, and if the body is restricted on that, so now that heart rate can't come up to compensate, so the blood pressure will start to drop because that heart rate is controlled, right? We can't control, the heart
It's
rate
inhibited.
isn't being done by the body, because, why?
It's inhibited by the beta blocker.
It's inhibited by the beta blockers. So those beta blockers are very, very important. If you guys are gonna take anything away from this entire thing that we talked about today, is the understanding of how beta blockers work against the blood pressure when it comes to patients on a normal everyday basis. There are a ton of patients on beta blockers that will have a hard time regulating their blood pressure, and you'll get patients that present exactly like this, and people are like, oh my gosh, this person's going into shock, and just based on the vital signs, a little old lady that fell, but it's because she's probably maybe hypovolemic, maybe she's dehydrated, something like that.